Intravenous calcium gluconate or calcium chloride is a high alert intervention. While it is life-saving in cases of hyperkalemia or severe hypocalcemia, it carries a significant risk if one critical factor is overlooked. The golden rule is that check magnesium levels before you push calcium. Calcium and magnesium are competitive electrolyte. Magnesium is a natural calcium channel blocker. If a patient is severely hypomagnesiemic, the body cannot properly regulate calcium. Low magnesium inhibits the release and action of parathyroid hormone. Since parathyroid hormone is responsible for maintaining serum calcium, you cannot effectively correct a calcium deficiency if the magnesium is still low. Administering calcium to a patient with profound hypomagnesemia can exacerbate neuromuscular irritability or even lead to cardiac arrhythmias. Before giving calcium, especially if the patient is on digoxin, you must look for a specific finding on the ECG, the shortened QT interval. If the patient already has a short QT interval, they may be already hypercalcemic. Adding more calcium can lead to heart block as it slows conduction through the AV node. Sudden stone heart syndrome or systolic arrest is another possibility. If a patient is taking digoxin, you must be extremely cautious. Digoxin works by increasing intracellular calcium. Giving intravenous calcium to a digitalized patient can cause worsening of digoxin toxicity, which can precipitate fatal ventricular arrhythmias like tosse à point or ventricular fibrillation. If you must give calcium to a patient on digoxin, it should be administered as a slow infusion over 20 to 30 minutes rather than as a rapid bolus. Here is a quick reference checklist. Check magnesium. Calcium won't stick or rather remain in circulation without correction of hypomagnesemia. Magnesium levels less than 1.5 mg per deciliter can be considered as significant. If the person is on digoxin, calcium potentiates digoxin toxicity. You can look for history of congestive heart failure and medications for atrial fibrillation, which could include digoxin. Check QT interval on the ECG. Shortened QT interval suggests existing high calcium. Digoxin can also shorten the QT interval. QTc or corrected QT interval less than 390 milliseconds is significant. And regarding patency of intravenous line, calcium is a vesicant, especially calcium chloride. So look for infiltrated peripheral line and it could cause danger of extravasation. Final clinical takeaway is fix the mag to fix the cal. Always ensure magnesium is being replaced concurrently or previously, and always check the medication list for digoxin to avoid a calcium-induced cardiac event.